Welcome back to PBH 275, Injury Prevention and Control. This week's module topic is Injury Prevention, Identification, Response, and Countermeasures. This week's module will be slightly different in that it's not going to cover any one particular injury topic. Instead, we're going to look at injury prevention a little bit more globally, sort of regardless of topic, some different ways that you can think about injury prevention. We're going to talk about the 4 E's and the role that they play in injury prevention. That would be education, engineering, enforcement, and also the environment, one that you maybe have not heard as much about compared to the other traditional 3 E's. We're going to talk about cross-sectional approaches in injury prevention and different ways that you can layer, target, and frame your prevention strategies, and also different ways you can dissect the injury topic into components so that you can find out where interventions might be most amenable. These are things you're going to have to think about for your upcoming major assignments. The first of these major assignments coming up is the Haddon matrix, which is one method of sort of framing and dissecting an injury topic that you're going to actually use for major assignment number 2. And then, of course, all these framing and layering and targeting and sort of getting the wider lens view of your injury topic is going to help you in major assignments number 3 and 4 as well. This is just a quick reminder that there are several assignments, 4 major assignments and 1 discussion board assignment, that in a lot of ways are kind of tied together because they build on each other, and kind of a reminder of where you are at this point in the semester. At this point, you already should have completed major assignment number 1, where you chose a particular injury topic that's in the CDC WSCARS data system, and you looked up some data on that particular topic. Now, you might or might not have decided to use one of the injury topics that happens to be a category in WSCARS as your selected injury topic that you wrote about in discussion board assignment number 3. Or you might have picked an injury topic that was not one of the categories of WSCARS, and that's perfectly fine too. A lot of students find it easier to choose an injury topic that happens to have that happens to be one of the major categories of injury listed in WSCARS, but you don't have to. But the point is, you should have already gotten to this point where you've picked your injury topic, and in the next few weeks, you're going to have to complete a Haddon matrix for your injury topic. You're going to have to do the injury prevention plan, which can consist of at least 3 different elements, and then you have to complete an academic poster for your selected injury topic. So there's still much to go in this semester with your selected injury topic. And of course, this is not an exhaustive list of all the assignments remaining in this semester in this course. These are just the ones related to your selected injury topic. The rest of this lecture is going to contain a lot of different hints and tips for how to do some of these major upcoming assignments that have to do with your selected injury topic. The first of those major assignments, number 2, is the Haddon matrix. What the Haddon matrix does, and I'll show you an example of it in a little bit, it provides a multidimensional look at your selected injury topic. So you get to see your injury topic, categorized based on contributing factors and also at 3 different temporal points. Those 3 different temporal points are pre-injury or pre-event, things that happen before the injury occurs, injury or event, things that happen while the injury is occurring, and then post-event or post-injury, the events and the conditions that predominate after the injury has occurred, which can either improve or in some cases make the injury worse. There will also be 4 categories of contributing factors that you will put in your matrix. These are things such as human factors, then agent or vehicle factors, physical environmental factors, and finally sociocultural environmental factors. And this will all make sense soon when you see the example. For major assignment number 3, you're actually going to draw up an injury prevention plan, because if you've made it this far in the public health curriculum, I think you understand that, yes, recognizing problems, measuring problems, coming up with data showing the magnitude of problems, that's important. That's an important part of public health. But we need to do more than just recognize problems. Good public health is also about proposing solutions, and then also testing solutions, making sure that the things that we come up with actually work to improve the public health outcomes of whatever the particular item of concern is. Because a lot of times public health involves the expenditures of public money. So we need to make sure whatever we're doing is not just a pet project that doesn't really do anything, but it actually achieves some results. So yes, we need to propose solutions, but then also test them. So what you're going to do for major assignment number 3, the injury prevention plan, is you're going to come up with at least 3 intervention strategies to help prevent the injury, or if not prevent the injury, at least mitigate the severity of the injury, make it more survivable. And my hope is that in looking through literature, you'll come up with some evidence-based things that maybe have already been tried in other contexts. You might come up with some things that maybe haven't been tried before, but you think might work. But regardless, that's what you're going to be doing for major assignment number 3, the injury prevention plan. And then major assignment number 4, the academic poster. That's basically an effective and efficient way to neatly and quickly present your findings. For example, if you're going to an academic conference. And at academic conferences, academic posters are actually printed out. You have a big, 3 by 6, for example, foot poster that's printed off that you stand in front of and talk. For this assignment, you will simply put up a PowerPoint slide that has all the components of a poster, and then you will do some voiceover narration on it, sort of simulating what it would be like if you were in front of a poster at an academic conference having to explain your injury prevention plan. So those are the 3 major assignments that have to do with your injury prevention plan. And there's one more major assignment, which has to do with writing a reflection paper on there are no accidents, but this is just kind of a reminder of where we are at this point in the semester. As you start to think about your selected injury topic and how you want to address it, and how you want to visualize the approaches to improving outcomes, probably a good first start is to remind yourself of some of the core functions of public health. Really, at its heart, public health is about assessment, policy development, and assurance, those 3 elements. And assessment is where we actually monitor health statuses, diagnose and investigate, and this happens with injuries too. I mean, we figure out if there seems to be an unusually high number of emergency room visits from kids falling off a particular piece of playground equipment, or a lot of collisions at one intersection where maybe there's not enough lighting or good enough signage. And so we do assessment to figure out where the problem issues are. And then comes policy development, where we combine our own knowledge that we learn from our investigations with the knowledge from the community, the affected community, through the formation of community partnerships and through education and empowerment and learning what's going on. We combine the knowledge of the community with our own knowledge, and we develop policies. So that's the second of the core functions of public health. And then finally comes assurance, which is critical, sometimes overlooked, where we come up with laws and policies, actually like enforceable policies that go into the communities to sort of help address some of the root causes of injuries or illnesses. We make sure that care where it's needed is provided, because unfortunately, no matter what we do, injuries might still occur. So we need to make sure that tertiary care is available and also rehabilitation. And then the most important element, I think, of assurance is evaluation. Like I said before, a lot of times public health is paid for with public dollars, which are limited. So we need to make sure that this precious resource is being used toward things that actually achieve desirable outcomes, not things that don't achieve desirable outcomes, or worse yet, have unintended negative outcomes. The epidemiologic triangle is another framing device that a lot of people find helpful when they're thinking about their injury topic, or really any public health topic. Because almost every bad thing we can think of in terms of public health can be framed this way, whether it's a chronic illness or an infectious disease or an injury issue. There will be a host. Those are the people. Usually it's people. It can be other species as well, though. But it's the creatures, the beings that are susceptible to being injured or suffering the illness. There's the agent. That's the thing that's causing the injury or the illness, the thing that directly impacts the host and causes the injury or illness. Then there's the environment in which both the host and agent reside, and in some cases the environment helps foster these negative interactions between the host and agent that lead to injury or illness. In some cases, the environment can actually prevent or buffer interactions between the host and agent so that the injury or illness is lessened. So this should be familiar to many of you that are public health majors, this framing, where what we do is we think about the host, the agent, and the environment, and we figure out where is the point that's most amenable to intervention so we can stop the injury or illness from happening. The public health approach, as we know it, was originally designed for the prevention or mitigation of infectious disease risk. But as it turns out, the public health approach also works very well toward injury prevention issues as well. And I mean, just step by step, you can see how there's great similarities and how it works. I mean, you start by finding out, is there a problem? You measure the occurrence of disease or injury problem. That's surveillance. That's what you did when you did your WSCARS data assignment, major assignment number 1. And this is, again, the assessment part of the 3 core functions of public health. Once you've done the measurement, then you identify relevant risk factors. This would be an epidemiologic analysis where you try to figure out, are there patterns in this data? Are there certain interesting vulnerabilities, like is there regional differences in this injury or illness problem? We're talking injury problems here. Are there sociocultural or demographic differences? Are there uneven numbers across racial and ethnic lines? I mean, this is all epidemiologic analysis, and it's also part of assessment. The next part is where you come up with interventions to reduce the number or severity of injury cases. And again, you can't just do this by collecting data and then proposing things. You actually have to work with affected communities and populations to kind of collect some of their local knowledge, get some of their opinions on the issue, find out what sorts of things have been tried before and didn't work, and just, you need to do this anyway, because any interventions that you want to come up with, if the local affected communities are not buying in, it's not going to work. And so this is why community-based participatory research is such a key to a lot of public health, including injury prevention. And among the 3 core functions of public health, all of this falls under policy development. And then finally, you evaluate results. Was it effective? And that falls into the core function of assurance. And then, of course, if you want to simplify that, you could think, which leg of the epidemiologic triangle is most effective to target? Is it the host? Do we want to train the host or harden the host to make them less susceptible to injury? Do we want to address the agent? Is the agent something that can be addressed? I mean, as we'll talk about later on, we can't get rid of all swimming pools if we're concerned about drowning risk, or get rid of all access to beaches. So in some cases, the agent can only be partially targeted. And it's the same with the environment. In some cases, the environment is a good target for a public health approach. In some cases, it is not. But you can see these are a couple different ways of sort of framing your injury topic, and therefore maybe coming up with some creative ideas about it. Perhaps one way that injury prevention might differ slightly from the way that public health deals with, for example, chronic disease and infectious disease prevention is that we just have to acknowledge that there's a lot of different organizations and stakeholders that can have an impact in public health when we're talking about injury prevention. If we're trying to create safer environments, we need to have people involved, such as engineers and architects and urban planners. With disease prevention, a lot of times the focus has traditionally been certainly on public health workers, but also medical workers and training individuals on symptom recognition, getting screened, those kind of things. With injury prevention, you kind of have to open up a whole nother world of collaborators in order to do it very well. I mean, transportation policy is public health, urban design is public health. So many different things are public health, particularly when it comes to injury prevention. Certainly, public health has to research and identify risks just in injury prevention, just like in disease prevention. and assessing the development of community coalitions. Having different voices often results in change. Certainly it will make sure that whatever policy solutions come out might actually be adopted and accepted in the communities where they're most needed. And then, of course, as public health professionals or future public health professionals that are focused on injury prevention, we develop injury prevention programs, which is what you're going to get to do for your selected injury topic. So now let's move our focus away from public health in general and more back to injury prevention public health in particular, and some of the prevention measures and strategies that can be implemented. If you're going to develop countermeasures, to prevent an injury or mitigate an injury, they can address one or more temporal phases of an injury event. They can address the pre-event temporal phase, the conditions that happen before the injury occurs. This is where we probably want to have most of our attention, because if we can stop the bad thing from happening, nobody gets injured. That's not always realistic, and so we always need to consider the other temporal phases as well. The event, what are some things that happen during the injury event where public health measures can assure that maybe the transfer of energy is mitigated somewhat so that the severity of the injury is lessened. And then, of course, post-event. This is probably more where medical care and rehabilitation and the access to emergency medical services is a little more important. I mean, in that case, we didn't stop the bad thing. There was some injurious energy that was transferred, and now we need to try to save somebody's life, stabilize them, eventually get them some rehabilitation so they can regain some lost function. And those happen to be the three temporal phases of the Haddon matrix. You can also really should think about your injury prevention topic in terms of the traditional 3 E's of injury prevention: education, enforcement, and engineering. And in general, I believe that the way I've listed them there is kind of in from least effective to most effective. Education, while it's important, generally education by itself does not remove injurious factors from an environment. I mean, it just sort of tells people how to navigate through an injurious environment and be safer. That's important, but it's not nearly as good as the other E's. Enforcement, we'll talk about some of the strengths and limitations of enforcement as an injury prevention strategy later on. And then engineering, this is better because with engineering you often will put a barrier between the person and the agent that could injure them, something that absorbs some of the energy or maybe even all of the energy. I mean, engineering controls do have some of their own limitations, but they're generally better than enforcement or education. And it's not talked about in most public health textbooks, but I really believe there's a 4th E, and that's environment. Some injury control professionals in the past have lumped environment in with engineering, but I don't think it should be. I think it really is its own thing. The environment is the milieu that we all live in that creates injurious conditions. If we can change the environment, then so that the environment is that milieu that we all live in that creates injurious conditions that we become exposed to. So if we can change the environment and remove and sort of address some of these factors, I mean, that's a little bit different than engineering controls. With engineering, you're still talking about the hazard being present. You're just making it safer through some designed-in things. Changing the environment is a little bit farther upstream and requires a little bit more in terms of expense and changes to society and the way that we live. I'll get into this in a little bit more detail later on. But I really do believe that environment is a 4th E that is probably even more important than the other 3. We'll start now with the first E, education. One of the ways that you can use education for injury prevention and public health is to use educational tools to persuade persons at risk to alter their behavior for increased self-protection. In other words, just show people that, show them the data, make it meaningful to them, and show them that there's certain ways that they would want to behave in this world to reduce their chances of this bad thing happening to them. No texting while driving campaigns are one example of this that's been where it's a very persuasive form of education. Of course, there are limited effects to this type of education because, again, it doesn't do anything to address upstream factors. It's really about trying to persuade independent people to alter their behaviors. And sometimes there's even an incentive for people to continue the behaviors that we as injury control professionals feel they should not be doing. So that's one of the limitations of persuasion and really education in general. But sometimes persuasion campaigns can be strong enough that they can actually mobilize people to make demands for engineered solutions to problems. We'll talk about this later on when I talk about poisoning and how drug companies being persuaded by concerned parents and caregivers to create child-resistant caps. That didn't just happen organically. It was because of some educational campaigns led to parents and caregivers demanding some engineered improvements, some enforcement improvements. A lot of the, well, I mean, one of the most influential organizations in the U.S. in terms of drunk driving prevention is called MAD, or Mothers Against Drunk Driving, where mothers who had been impacted by DUI events, in some cases they had lost family members to drunk driving events, demanded changes to the way that drunk driving laws were enforced and the severity of them. And so, yeah, persuasional education campaigns can actually mobilize people to make demands for engineered improvements, enforcement improvements, maybe even to change the environment. So they're not unimportant, even if they're not necessarily the highest ranked of the four E's. If we're going to try to use persuasive educational strategies as an injury prevention tool, we have to acknowledge a truth, first of all, which is that lack of knowledge about the injury topic is usually not the problem. It's usually more from people not being able to apply what is known, either because they maybe don't know how to apply it, or in a lot of cases, there's actually differing incentives in their life that sort of incentivize, driving faster, maybe not maybe doing some other things that are really not safe behaviors, but the milieu in which people live sort of incentivizes unsafe behaviors. So if we want to, in lieu of these facts, if we want to use educational persuasion strategies, there's several goals. The first one would be, yeah, you want to provide information regarding the risks. Now, some of them are apparent. I mean, if you've been to many national parks and you've seen signs near cliff edges that talk about, caution, do not attempt to climb, or if you're going to try to do free climbing or something, that there are significant risks involved and dangers. I mean, that's a very apparent risk. Nobody would be surprised by that. Now, some risks are not as apparent. I talked earlier in the semester about it was not necessarily apparent to a lot of people that baby walkers were particularly dangerous because people thought, hey, it's going to prevent the baby from falling over as much when they're learning to walk. But actually, the data shows that, and this is why the Consumer Product Safety Commission does not recommend their use anymore, that if children fall just on their own onto the floor or something, that's usually not a dangerous fall. But if they fall into a baby walker and hit their head, that can be a catastrophic injury event. So that was an example of where education is important because the risks were not necessarily readily apparent. Sometimes, in order to get people to use devices that are perceived as being uncomfortable or inconvenient, we have to go to data, and the data has to be fairly persuasive. An example of this would be, a lot of people don't like to use helmets when they ride bicycles or scooters or other wheeled conveyances, but the evidence is just so compelling when you look at it. I mean, if you're wearing a helmet and you're on some kind of wheeled conveyance and you have a collision injury, you have a collision event, you're 69% less likely to have a head injury, 65% less likely to have a brain injury, and 74% less likely to have a traumatic brain injury, the type of injury that alters the course of the rest of your life, if you're wearing a helmet. Those are huge statistical advantages, which if we can persuasively educate people about those and maybe do some other things to get over some barriers, such as provide helmets, we can make a huge public health impact just through persuasion and education. We can also focus our persuasive educational strategies on trying to change attitudes toward risk and safety, because this is often the problem, where people don't perceive that a hazard is really hazardous for them. People feel like the danger doesn't really apply to them. People say things like, "I know how to text and keep my eyes on the road. I can multitask well. I've done it for many years." Or, "Yes, my child can handle this toy even though they're under the age of 2 and it's not meant for 2-year-olds. I know that they're smart enough and well developed enough. They're not going to pull this part off and try to swallow it." Or the thing that I heard a lot, that I've heard a lot, which is, "We did this growing up and we're fine." And whether you apply that to lawn darts or three-wheeled ATVs, or, as I talked about several weeks ago, riding in the back of a pickup truck, in the bed of a pickup truck if you're a child. I mean, it took several years to change the attitudes towards risk and safety, but now you will not see children riding in the back of pickup trucks at high speeds on like highways. The attitudes towards that risk were changed through a lot of persuasive campaigns, a lot of public service ads, and you have to be really patient if you're going to try to apply these, because these attitudes do not change overnight, but they do change. I mean, within my lifetime, the attitudes toward riding in the backs of trucks, toward drunken driving, toward wearing seatbelts, were all changed, in the course of my lifetime. The hardest thing to do, but if you can do it, is probably the best thing to do, is to actually use persuasive educational strategies to alter behaviors, where people actually adopt the behavior that we feel lessens their injury risk and sustain that over time. That's really hard. It also takes a very long view. It is doable, though. For injury prevention involving education, we need to think about who is the focus of the strategy or plan, because there's different layers of population, and the way that you try to reach them is going to be different. What we use in public health a lot is what's called the USI model, where there's 3 levels of activity. There's universal, there's selective, and there's indicated. In this case, universal means that you offer the strategies and the education and the materials to everybody, regardless of their level of risk. Selective means that these educational strategies are targeted to groups identified as having an increased risk. A lot of different things in public health, including injury risk factors, are not evenly distributed in the population based on geography, socioeconomic factors, race, ethnicity, gender identity, many other different things. So with selective, we're kind of targeting your interventions to not to individuals necessarily who have increased risk, but to groups who have increased risk. And then finally, indicated prevention. In this case, these are the types of activities that are targeted specifically to people who have shown, basically they've already shown propensity to be affected by this risk factor. Maybe people that have had repeated DUI collisions, or people who have survived an overdose, people who have shown propensities or tendencies toward inflicting non-suicidal self-injury, such as cutting. I mean, indicated prevention is very specific, targeted towards specific individuals are who are showing signs of being deeply affected by an injurious risk factor. The first U on the USI model is universal. And with universal education, we're talking about activities targeted to the general public or the whole population of a particular region. These are people who are not identified on the basis of risk. Therefore, nobody is being singled out for this education. Examples of this would be handing pamphlets out to all parents and caregivers at a school assembly, such as the pamphlet shown here, The Dangers of Prescription Drug Abuse. A school curriculum on substance abuse that everybody has to take, where people aren't diverted into this curriculum based on known or suspected substance abuse instances with the child or with the family of the child. And then also public service announcements. Now, public service announcements can be somewhat targeted depending on what time of day and what programs on which they air, but for the most part, with a public service announcement, it's educational information for just about anybody. An important thing you have to consider with universal education is the fact that a lot of different people are going to receive the message, and you've got to consider all of these people based on their cultural norms, how they might perceive and understand the message, and so you have to consider everyone who might receive the message. An example would be, a few years back, the state of Maine legalized recreational cannabis. But as part of the legalization of cannabis, the Maine Department of Transportation wanted to make it clear to people, to residents of Maine, that you cannot get high and drive. If you do drive while you're high, you can be cited or arrested. Now, in the state of Maine, the particular crime you would get charged with if you were intoxicated on marijuana and were pulled over would be called operating under the influence, or OUI. So they put these flyers up all over the state of Maine saying driving high equals OUI. Well, if you've ever been to Maine or have spent any time there, it's a very interesting place. And one of the things that's interesting about Maine is that there's a sizable population of Acadians, especially up in the northern part around Aroostook County. And Acadians, they came from French-speaking regions of Canada, and French is still the home language of a lot of these people in Aroostook and other areas of Maine. So to somebody who is a French speaker, this message would appear to be saying driving high, yes. So again, it might sound like a silly example, but if you're going to do universal education, you have to consider everyone who might receive the message. Here's another recent example that's a little bit closer to Nevada, in this case in the state of South Dakota. South Dakota has been reckoning with a methamphetamine addiction crisis for many years, and the state of South Dakota decided to launch a campaign to sort of make people aware of the problem and point towards solutions. Now, the rather strange slogan they used was, meth, we're on it, with a bunch of people in the video public service announcement saying, I'm on meth, but then after that, when you watch the video public service announcement, it's clear that despite the provocative slogan, what they're really trying to say is, we are serious about methamphetamine, and we're serious about trying to do something about it, and everybody needs to be involved. Okay, interesting message, provocative tagline. The problem was that this message was accompanied by a lot of printed promotional materials like what you see here. And in print, a lot of the subtext is lost. I mean, if you're just look at the big print and the pictures on these flyers that were posted throughout public offices in South Dakota, you would think that they're advocating for the use of meth, particularly if you're a senior citizen rancher or a young high school football player, that methamphetamine might be giving you vitality or helping you play better or something like that. So this was I think maybe they were trying to go a little bit viral with this campaign, but in trying to do that, the message was lost somewhat, and it became maybe an example of not particularly good universal education on a public health topic. The next layer of the USI model is selective education, and these are activities targeted to subgroups whose risk is significantly higher than average. Again, these are groups for which we know the risk of certain types of injury is much higher based on data that's collected, starting with local hospital and health departments, and then that data goes up to the CDC and gets processed and put into WSCARs or other types of database systems. And we know there are some injury events for which certain subgroups have a significantly higher risk than the population as a whole. Some examples of selective education would be, we know that tribal American Indian populations have incredibly high rates of being injured or killed as pedestrians by motor vehicles. So pedestrian safety activities targeted at tribal American Indian populations. Instead of the example I talked about before, where everybody at a school gets a substance abuse curriculum, maybe target this education only to the children of substance abusing parents or caregivers would be enrolled in the curriculum. Now, if you're going to do selective education, you have to be sensitive and you have to take cultural considerations into account. If we're thoughtless with our selective education, it can be patronizing, it can be insulting, it can even be triggering. And so they always have to be very cautious about this, because if you were if you were a member of any type of group, what be it a racial group, ethnic group, socioeconomic group, regional group, they had a kind of a high rate of a particular negative injury outcome, but you yourself didn't feel like you were particularly at risk for this, and you were told you had to take this training because of some characteristic that you couldn't do anything about, it would be very, yeah, it could be very troubling and insulting and triggering. So we have to be sensitive and take cultural considerations into account before we start doing any types of selective education. The final level in USI is indicated education. These are educational activities targeted to individuals in high-risk environments, individuals who might have already shown some detectable signs or foreshadowing that they are in danger of particular injury events or other negative health outcomes occurring to them, or they maybe even have biological markers that are predictive of certain events. Some examples of indicated education would be specific education toward for in schools for teenage boys who strongly identify with the social construct of masculinity, and if and as they start to show some of the negative and in some ways antisocial elements that go with some of the more damaging uh, expressions of the social construct of masculinity, they can have indicated education. Another example would be anyone is showing suicidal ideation. If they're people who are talking about the world would be better if they were not here, or showing some other signs, some of the early warning signs of suicidal ideation, having indicated education just for those people. And a lot of times this indicated education is focused on adolescents as they begin to show behavioral problem issues such as skipping school, abruptly starting to fail when they were doing fine before, and maybe signs of substance use, visible and not so visible. So the thing with indicated education is that it is directed at individuals. It's really not directed at populations or subgroups or categories. It's directed at individuals showing very obvious warning signs. So it doesn't have as big of a reach, but the people who are being given this education are the people who are absolutely clearly most at risk. So there is a role for indicated education, even if its reach does not go very wide. When we talk about injury prevention and control, the next of the four E's is enforcement. With enforcement, what's happening is it's a requirement that individuals change their behavior. And this requirement can be due to a law or an administrative rule, or maybe just even a social and societal expectations. Some examples of enforcement actions that have been used for injury prevention and control include seatbelt wearing, DUI, and speeding laws, where if you're going to be operating a motor vehicle, you better have your seatbelt fastened or else you could get a ticket for that. You certainly cannot drive impaired or under the influence, and you have to obey posted speed limits. Most of the time, people don't get tickets or citations for speeding violations unless they're going a significant amount above the speed limit, 10 to 15 miles per hour, but that's what those laws are for. Prescription drug monitoring programs. This is something that was introduced over the last couple decades because a lot of prescription drugs were getting diverted into the illicit drugs market, particularly painkillers. We've had a whole module about painkillers and about the opioid epidemic, but prescription drug monitoring programs, I mean, those are enforced by pharmacists and pharmacy techs, where if you have doctor shopped or appear to have a forged prescription, or according to records, you've gone to too many different places trying to get something filled, they have the administrative authority to deny the prescription. There's a lot of different OSHA regulations that certainly fall into the realm of enforcement. For injury prevention, probably the most pure example we have is the fall protection regulations. Many of you have probably noticed when you're in the workplaces and the jobs that you work, either full-time or part-time, that you're never exposed to a fall of greater than 4 feet without there being standard railing present. And that was an OSHA law that in general industry you cannot be exposed to a fall of greater than 4 feet. In construction industry, it's 6 feet. So a lot of the regulations around, cages up on fixed ladder systems, guardrails along docks, things like that, those are actually enforced by the Occupational Safety and Health Administration, which is a administrative agency given powers by the legislature, and they hire compliance officers to do the actual workplace inspections. Indoor smoking restrictions, that doesn't necessarily have a lot to do with injury prevention and control, unless you're of the mind that if you suffer from a chronic disease many years later after being exposed to secondhand smoke or third-hand smoke, that maybe that was caused by an initial injury event. And yeah, the line between injury and illness or disease is a little bit blurry there, but certainly indoor smoking restrictions are an example of an enforcement activity, in public health at least, even if not injury prevention. And enforcement can have an impact on social norms. Once something becomes not allowed by law enforcement or other official enforcement mechanisms, there does become a little bit of a sort of a social tax on doing that thing. So yes, they can have an impact on social norms as well. Now, as I alluded to earlier, not all enforcement actually comes from sworn law enforcement officers. If your workplace gets inspected by an OSHA compliance officer, they're not a sworn law enforcement officer, they're just an employee of either the Federal Department of Labor or the state OSHA office. And yes, they can propose monetary penalties and other remedies, but that can be backed by an administrative law judge. But yeah, they're not sworn law enforcement officers. Neither are the environmental investigators that often come whenever a spill event occurs that could cause harm to the community and the environment. The EPA and state-level EPA inspectors, they're not sworn law enforcement officers either. So anyways, I just want to reiterate that yes, enforcement is largely associated in our minds with law enforcement, but there's other types of enforcement and injury prevention that do not involve sworn law enforcement officers. State legislatures have been relatively active in promulgating legislation that has to do with injury and violence prevention. Just in the year 2019, this is data from the National Council of State Legislatures. In the year 2019, there were close to 100 injury prevention legislation laws passed in states. They had to do with prescription drug prevention of overdoses and diversion, and also treatment. I would imagine a lot of those prescription laws had to do with the provision of Narcan and naloxone hydrochloride in many public areas and training people on how to use them, particularly public employees. There were several pieces of legislation introduced that had to do with dealing with the effects of adverse childhood experiences. And there were many that had to do with addressing child maltreatment or avoiding traumatic brain injury or teen dating violence, and a couple to do with elderly falls. So again, it's just one random year, 2019. In a given year, the states of our union here in the United States will tend to promulgate a lot of legislation that when you look at it carefully is really about injury prevention. If you're wondering about Nevada and state injury prevention laws, in the 2021 legislative session, there were a couple of bills passed that, if you look at them carefully, you can see at least have a tangential connection to injury prevention and control. One important law that was passed in 2021 had to do with implicit bias and cultural competency training. What this required was that if you're an employee, a state employee in the Department of Justice in any of its forms, be it sworn law enforcement, the courts, clerks, anybody who is part of the Justice Department at the state level, would have to receive periodic training related to implicit bias, cultural competency, and this is the important part, the impact of trauma and adverse childhood experiences, or ACEs, on the behaviors of children. You know, the hope is that by mandating this training that maybe the criminal justice system will be a little bit more understanding of the effect that adverse childhood experiences have on, particularly on adolescent and young adult behavior, and consider that when it's determining what kind of remedies are necessary for if if some of these actions lead to laws being broken. There was also an important law passed in 2021 that enabled, you know, basically that Narcan or naloxone hydrochloride, an opioid antagonist, could be administered by public or private school employees. They could obtain and then maintain these under certain conditions. There would no longer be a prescription required to obtain Narcan and naloxone. And also, it provided a little bit of extra liability protection so that anybody within the school system or any public employee could not be sued for acts of omission relating to or acts of commission relating to the use of either opioid antagonists or auto-injectable epinephrine. The next E is engineering controls. Engineering controls are good because they provide automatic protection by design. If you have a structure with a built-in sprinkler system that's automatically activated when the fusible link gets above a certain temperature, that can reduce the likelihood of not just fire injury, but also smoke inhalation injury occurring in occupied buildings. Divided highway is another example of an engineering control. It was quickly determined in the United States that if we could have divided highways where, at least in theory, cars are going in the same direction on the different sides of the road, and so there's not as many head-on collisions, that would greatly reduce the most dangerous collisions, which are the head-on collisions, because that's when the most energy gets transferred. Then engineering controls got more advanced in cars, and airbags became a thing where upon a collision, these bags would explosively inflate and would absorb a lot of the crash energy that the driver or passenger is exerting against their belt, against possibly the wheel or the dashboard, and so it mitigates the injury quite a bit. Another example of engineering controls are apps that block certain phone functions whenever your phone senses that you are driving in a vehicle. Of course, they also would block it if you're riding in a vehicle, but these are just examples of engineering controls that provide automatic protection just by their design. Now, as we'll talk about shortly, engineering controls, they should not be used in isolation because generally the underlying hazard still exists. There's just something between you and it. And so they shouldn't be used in isolation. Some other examples of engineering solutions that design safe and create safer physical surroundings and reduce the likelihood of injuries or mitigate the severity of injuries include dedicated pedestrian walkways and dedicated off-road bike paths. In this case, the vulnerable road users, be they pedestrians or bicyclists, they have a designated place where motor vehicles should not normally be present. So the likelihood of there being a collision between pedestrian or bicyclist and a motor vehicle is very much lessened. What used to be a common injury and death issue in the United States back in maybe the 1960s through the 1980s was people who would fall asleep or pass out while smoking a cigarette, and the cigarette would fall down onto the couch or onto bedding or something and catch it on fire, and that would very quickly lead to a catastrophic structural fire. Well, cigarettes in the ensuing decades have actually been designed so that the cigarette paper is the porosity of it is different now, so that if air is not actively being pulled through the cigarette, for example, by a person who's actively inhaling on one, the cigarette will tend to kind of put itself out relatively quickly. It doesn't really smolder like the older models used to, so that if somebody is not actively smoking it because they're asleep or passed out, it usually just kind of puts itself out relatively quickly. Again, that we don't necessarily think that we don't agree that cigarettes are good for people, but if people are going to smoke them, it's better to have a safer one that is less likely to catch their house on fire. I've talked before about shock absorbing playground surfaces, a really great engineering control that's probably mitigated a lot of injuries, maybe even saved some lives. Engineering control solutions have also been brought to consumer products to make them safer and reduce or mitigate the risk of injury from them. Some examples of this would be almost every lawnmower you get now, whether it's a riding lawnmower or a push mower, has what's called an operator presence control. The less politically correct term for that used to be dead man switch. And the point of that was if you were not, when you were not grasping the handle or you were not on the seat, if it's a riding mower, the blade would automatically turn off. This, pre- this prevents a lot of injuries when people are trying to unclog a deck and they get up off of the mower or walk away from the handle of the push mower and try to go under the deck to clear it. If the blade is still turning, that can be a horrible injury hazard. Well, most modern mowers with the operator presence controls, that physically cannot happen anymore. Cribs that infants and toddlers sleep in now have much closer slats now than they used to, which makes it a lot less likely that the infant is going to wedge their head in between them or any other vulnerable body part. A lot of plumbing fixtures now have anti-scald features on them so that the water cannot get to a temperature that would actually scald the skin, even if you inadvertently turn the water all the way to H, maximum hot setting. One evidence-based solution that really does work to ensure that firearms are not improperly used is what's called personalized or smart gun technology. Now, this is a technology where a gun will not fire unless it recognizes the biometric data, meaning the prints, of the person who's like the registered intended user of that firearm. As you can imagine, smart guns have not been particularly popular in the United States because a lot of people who advocate for no restrictions on firearms and people that tend to want to have a lot of guns are also people who don't necessarily want to give any government official or even a company their biometric data. So yeah, personalized or smart guns, they work really well, but they're not real widely adopted yet here in the United States. Another engineering control is to redesign operating protocols and practices. This would be things such as for streets, where there's often a lot of potential negative interactions between pedestrians or other vulnerable road users and motor vehicles, is to have longer walk timers so that when a person presses the walk signal and they get the walk signal and they're crossing the road, they actually have enough time to get across before it turns yellow and then red. Even if they're a relatively vulnerable user who maybe has to have an assistive device, there's still enough time for people of all abilities to get across the crosswalk and the intersection before the light changes. Traffic calming measures, these include things such as speed tables, speed bumps, roundabouts are kind of traffic calmers too because they break up the straightness of the road and encourage everyone to go a little bit slower. Certainly well-lit streets, the more lighting you have, the more likely it is that people inside vehicles will see the vulnerable road users out there. Outside of streets and inside places like workplaces, it's been found that if you slow a factory operation speed, particularly on sort of high throughput operations such as chicken or other meat processing plants, that the more you slow it down, the fewer injuries you have. And that's just something that unfortunately a lot of employers don't embrace that because they feel if they slow down, they lose money. But the truth is, by speeding up their operations, they're also losing money because of all the workers' comp claims that are occurring. Because as people work faster, they take shortcuts. They don't. Their bodies don't have time to recover, and it's just slowing factory operations particularly assembly line or other operations like that, is an engineering control that does work. We just need to implement it more. So one reason why engineering controls are good is that for the most part, they don't require a lot of behavioral change or even conscious effort of the person that you're trying to protect. Initial training is probably necessary to let people know why the engineering control is important, why they should not override it, why they need to report if there's any problem or issue with it. But other than that, it doesn't require a lot of conscious effort or much behavioral change. Engineering controls are often what we call passive and automatic. Now, with that being said, yeah, initial training is required on how to use it and why to use it, and then also maintenance is required. Engineering controls can fail over time. They can break, they can corrode, and people who are using engineering controls need to be trained to recognize when the controls are starting to fail so they can, if they're in a workplace, they can put in a request to have it repaired. For those of you that have worked in chemistry laboratories, or really any kind of laboratories that involve manipulating hazardous chemicals and using a chemical hood, what we often call fume hoods, they're great. They isolate the vapors of the chemical from the user, but they can stop working sometimes. The belts can break or they can start to slip, and it's important to recognize that, hey, this doesn't sound right now, or I'm getting fugitive odors when I'm using this hood that I was not getting before. And then actually speaking up and making sure those engineering controls get repaired. So there needs to be a training and recognition on when the controls are starting to fail, regular maintenance on them to keep them from failing. And the thing about engineering controls is that the underlying hazard might still exist. Yes, now there's something between you and the hazard, like maybe a machine guard or something like that, but the underlying hazard still might exist. So that's one limitation of engineering controls. So the last of the four E's is environment. And I personally believe that this should be separate from engineering, even though some people put changing the environment under engineering controls and just have three E's. What we're talking about here is fundamentally changing the environment in which people exist. That's milieu that we're all in, where people exist along with the injurious factors that could possibly harm us and the environment that's around all of us. So to change that environment might require a combination of education, enforcement, and engineering controls to implement. When we change the environment, what we're doing is we're minimizing or eliminating the need for the potential hazard to exist at all, rather than just educating people on how to avoid the hazard, or enforcing that you can't be close to this hazard, or even putting engineering control between the person and the hazard. We're actually going a little farther upstream and completely eliminating it. And I think it's reasonable to always ask if people need to be exposed, particularly in occupational settings, to certain hazards at all. Would our society actually be better overall if people were not exposed to certain types of hazards, particularly at work? You might remember during the occupational injuries lecture, I talked to you about Agricola, who during the time of the Roman Empire was really kind of radical in that in his writing, De Re Metallica, he talked about how silver wasn't such a valuable thing, that people needed to try to die to mine it. He he said that in no uncertain terms that nobody should actually mine silver, that it's just the occupation of it is just too inherently dangerous. It's just sending people needlessly to early graves, and that silver was not that important. And so I think we need to, for a lot of the particularly occupational things where a lot of people are getting injured, we need to be asking, would we be better off to just completely eliminate those hazards, automate those jobs, because they're causing a lot of immiseration just by their sheer existence. Anyway, it's just something to think about. Another example would be if we tried to discourage the use of personal automobiles. Automobile driving has been one of the most dangerous things that humanity's ever invented in terms of the number of people who have been killed or severely injured, had the course of their lives dramatically and traumatically altered. There's not much that would compare to the automobile. Any kind of policies that we can put out there, anything we can do to encourage the use of mass transit that would reduce the risk to individual drivers. It would also greatly reduce the risk to bicyclists and pedestrians and other vulnerable road users. I mean, of course, bicyclists and pedestrians could be struck by buses or trains, just like they can be struck by personal automobiles. But with mass transit, you're talking about generally specially trained drivers, people who know what to look for, and just the hazard of from an individual, from a pedestrian or a bicyclist from one bus or one train is a lot less than the hazard would be from 35 people in cars, which might exist if the mass transit was not there. And then, of course, as we encourage people away from personal automobile usage toward more forms of carbon-free transit, we help to deal with the bigger existential threat of climate change and climate disruption, which I know is not necessarily injury prevention topic, but it's still a very important public health topic. When we consider how we can change the environment, we can also see that changing the environment can address some social attitudes and conditions that have led to injurious outcomes, exacerbated injurious outcomes, and we can have a better society. I mean, certainly by changing the environment in the last several decades, we've decreased the social acceptability of sexual assault and violence, particularly intimate partner violence. Again, this used to be less stigmatized and honestly was not prosecuted as much either. But we've changed the environment in that way. We can change the environment and reduce the acceptability of cell phone use while driving. That's already starting to happen. We can change the environment so that bicyclists are respected as road users and given sort of equal rights and equal levels of funding per capita, and that their needs are deemed to be as important as the needs of people who are driving motorized vehicles. We can decrease the stigma surrounding mental health and mental health associated issues. And we can start to directly address some of the inequalities that we see in all forms of public health, not just in injuries, but all forms of public health, where the rates and the incidences are not borne equally in the society. There's gradients, often based on socioeconomic, racial, ethnic, and regional differences. And we can start to address some of that chronic stress, the allostatic load that is shortening a lot of people's lives and making lives more difficult, particularly for poor and low SES and specific types of minority populations. So changing the environment, we can make a society where people are less likely to be injured and also just live better lives. In summary, about the 4 E's, education is very important. I hope that I've emphasized this to you and I've not tried to, belittle or downgrade the importance of education as an injury prevention tool. It is very important, but just keep in mind, it usually does not remove injury hazards from society all by itself. It it shows individual people how to avoid certain injurious conditions. It also can have a role in changing societal norms, as we talked about earlier. So education is important, but usually can't remove the injury hazard by itself. Enforcement, one of the limitations of enforcement is that it's limited by staffing levels. There's only so many OSHA compliance officers or EPA inspectors in the US. And so the likelihood that that a potentially injurious condition at, for example, your workplace is going to be caught and addressed by an OSHA inspector in any given year is not that high. So staffing levels are definitely a limitation of enforcement, and so is a social contract. When I say social contract is that if you're driving here in Las Vegas Valley on the 215 and the speed limit is 65 miles per hour, and everybody's going 80 miles per hour, then we as society have collectively all agreed that 65 miles per hour is not the real speed limit. That's probably closer to 80. And when you see everybody else driving that speed, including Las Vegas Metro Police Department vehicles, then we really, by social contract, we've agreed that that's not actually enforced and that that's not actually important to us, that getting where we need to go faster is more important than the enforcement of this particular expectation. And if we talk about enforcement, particularly done by law enforcement, we also have to mention that it disproportionately falls on poor and minority populations. I mean, there's a lot of inequities in the way that different populations are policed. And also there's a lot of inequities in the way that people based on socioeconomic factors are sometimes able to get out of some of the violations and other fine-based enforcement activities that don't necessarily come from law enforcement, but that come from people who have the authority to do that. So yeah, enforcement often disproportionately falls on poor and minority populations. It's not usually uniformly enforced across a society. Engineering solutions, they're great, but they require maintenance and upkeep, or they might fail if you don't maintain them. Both engineering solutions and fundamental environmental change can be costly. They often face opposition, particularly by industrial interests if we're talking about workplace engineering and environmental changes, because people see the front-loaded expense of doing this and they don't think about the money they're going to save on the back end by having fewer people injured, plus the fact it's just the right thing to do. So yeah, they can be costly. Changing the environment also requires a fundamental re-examination of how our society is currently constructed. It requires you to ask why a lot. Why is it that certain communities have these types of noxious land uses and dangerous workplaces and more dangerous playgrounds for children, and why do some communities not? And those are uncomfortable questions, but they're questions that have deep roots in inequality and where we need to just fundamentally change the environment that people live in. And of course, we need to ask questions too about why are we so dependent on internal combustion engine motor vehicles? Why is our society constructed in such a way that people have to drive so much? Again, if we want to be serious about injury prevention and really be big thinkers, we have to ask a lot of questions about why our society is the way it is and what can be done about it. And how we design our built environment has the great potential to not just improve injury rates, but also address many of our nation's other great public health concerns. I mean, many of the social inequities, and things like violence and rates of asthma, cardiovascular disease, and obesity. If we change the way we design our built environments, we can improve all of these things, and have a lot of wins in public health. So it's always worth considering if it's possible. It might not always be possible. We should always at least consider it. You've probably heard many times that public health is in all policies, and that's really true in a lot of ways. I mean, when we talk about if we really focus on injury prevention, of course, public health agencies are going to play a major role. The medical and rehabilitation care communities will play a major role, but a lot of other local, state, and federal agencies have a role to play here as well. I mean, because zoning is public health. The way that police and fire department resources are utilized is public health. Certainly, sanitarians from the health department, they're enforcing public health every time they do a restaurant or pool inspection, as are alcohol control agencies and school health programs and traffic engineering. Even parks and recreation departments are public health. If communities have safe and healthy places where people can do recreation and where kids can play, the community is going to be healthier. If that does not exist, people are less likely to use them. Or if parks have dangerous playground equipment that is causing injuries to local children, that's a clear problem. So a lot of local governments and agencies have a lot of involvement in injury prevention, even if they're not what we traditionally think of as public health or even medicine. And at the state level, certainly building code officials highway safety, our departments of motor vehicles, agencies that license daycare facilities to ensure that there's no obvious injury hazards that exist in those, along with making sure that the training levels of staff is adequate and that they all pass background checks and are not representing any other threat to children. So yeah, a lot of different agencies at many levels are involved in injury prevention. There are also, as you would guess, many federal agencies involved in injury prevention. Your injury prevention plan that you draw up, you might want to consider putting in there what the role would be of some of these federal agencies, along with possibly state and local agencies. So some of these federal agencies includes the National Center for Injury Prevention and Control, which is housed within the CDC. Again, at first there was a little bit of resistance back in the early 90s when that was going to occur because they're the Centers for Disease Control and Prevention, and this had to do with injuries. But it turns out it's been a really natural fit, and now the CDC, the injury prevention and control elements of it, are just a natural integrated part of it. The National Highway Traffic Safety Administration certainly is involved in injury prevention for vehicles. The Consumer Product Safety Commission, certainly for consumer products. The Federal Aviation Administration, the Occupational Safety and Health Administration, the National Center for Environmental Health, and the Agency for Toxic Substances and Disease Registry. In all of these different agencies enforce laws and statutes aimed at minimizing injury. They also fund research on some of the injury questions within their areas of expertise. So, yeah, you might have a role for some of these federal agencies in your injury prevention plan. Let's now move on and talk about frameworks for injury prevention strategies. This is going to be very important to you for the upcoming 3 major assignments that have to do with your selected injury topic. Earlier in this lecture, I covered some frameworks that are useful for evaluating injury problems and also helping to develop injury prevention and mitigation solutions. I will go ahead and reiterate these real quickly. The first is the epidemiologic triangle, where you consider your injury problem in terms of host, agent, and environment, and whatever solutions or mitigations you want to come up with, you figure out based on where you think you're going to get the most positive effect. You target those potential solutions at all 3 points of the triangle, or 1 or 2 of them. There's the public health model, where we start with assessment and then go into policy development and then assurance. You can use that one as well. And also the 3+1 E's: education, enforcement, engineering, and fundamentally changing the environment. As public health-minded people, we're used to looking at some of the great public health problems, including how to prevent injuries, through the public health lens of always looking upstream. Before the event ever occurs, how can we intervene in such a way to stop it from ever occurring? And yeah, that's the public health lens, but as I'll talk about shortly, we can't always look upstream. I will talk now about the river metaphor, though. If you're not familiar with this metaphor, I'll go into it now. So there is a town that has a river flowing through it, and periodically people in this town are falling into the river and being swept away and drowning. So what the town does is a couple of things. First thing they do is they station some people, some well-trained people, slightly downstream of where the people are falling into the river, so that they can deploy life rings to people who are in the water. They're struggling. They're not drowning yet. Their heads are still above water, but they are going to drown if there's no interventions. And so they train their townspeople how to deploy life rings, get people to shore, get them the care they need. This town also decides to build a hospital and medical center that specializes right along the river with a dock that specializes in rescuing people that are in deep distress and then also treating them, for the severe injuries that happen when you're beginning to drown and when your tissues are rapidly losing oxygen. They have hyperbaric oxygen, they have well-trained doctors and everything like that. And that's good. Of course, with this metaphor of the river, you're probably wondering, as a public health minded person, What is going on upstream that's causing all these people to fall into the river in the first place? And wouldn't their best use of resources be to find out what that is and spend their resources there rather than focusing on midstream and upstream? So again, in this analogy, downstream are the people who are deeply affected, who have already been injured, and for whom tertiary measures for saving their life, stabilizing their condition, maybe giving some rehabilitation services so that you can get some function back after an injury. And then midstream would be people who are affected by the injury factors, where they didn't they weren't protected from the exposure happening in the first place, but the intervention happened relatively early so that the injury was mitigated and the long-term damage was minimized. This is where you get secondary prevention in many of your things. I mean, if you think about seatbelts, this is an example of a secondary prevention. It doesn't stop a crash from occurring, but it makes the crash much more survivable. And then, of course, upstream, this is where we tend to think of a lot in public health, where we're trying to do primary prevention. The bad thing never happens in the first place because we address the risk factors for the injury or the negative outcome before it occurs. But as I'll talk about next, there's a reason why I don't want you to have everything in your injury prevention plan only focused upstream. So here's why I don't want you only thinking upstream for your injury prevention plan, but also focusing some of your attention to downstream measures, secondary and tertiary measures. One of those is that, well, complete elimination of upstream risk factors is just not always a realistic goal. If you're creating an injury prevention plan that says that handguns will be banned, or motor vehicles will be banned, or swimming will be banned, that's not effective. And in fact, even suggesting something like that hurts the credibility of public health because those are not realistic goals, at least not in the way that our society is currently set up. And that kind of goes with the next point as well, which is that when we address upstream risk factors, sometimes upstream risk factor involvement means proposing restrictions on freedoms that society currently might not find acceptable. I mean, this is the case certainly with a lot of gun control measures, with measures that tend to limit the risky activities that some people find enjoyable, whether it's rock climbing or swimming or boating or things like that. I mean, the more restrictions we put on those kind of dangerous things that people enjoy doing or enjoy using, or driving is another example, the more that society is going to likely to push back against that. And so you always have to balance, if you want to work upstream, you always have to balance what you think needs to be done with what society will find acceptable, because otherwise you're not going to get anywhere with your interventions and with your public health, and it won't be credible. Finally, there's some socioeconomic factors we must consider if we want to think about the whole picture. I mean, for a lot of things, it's likely that there's going to be some populations remaining vulnerable to the injury because there's not always equal access to upstream solutions. An example of this would be in a lot of our current societies here in the US, dedicated off-road bike lanes. They're a great thing to promote bicycling as an alternate pollution-free form of transportation, and also for better cardiovascular health. These unfortunately tend to be built only in the most affluent neighborhoods, and sometimes it takes a long time for these to wind up in some of the neighborhoods where they would do the most good. Places with maybe lower socioeconomic levels where a dedicated safe bike lane would be a really good thing to have, but people just don't have I guess they don't have the political clout to get those things in those neighborhoods. Another example would be, well, really anytime you're talking about, say, getting people off the road and into clean, safe, effective mass transit. There's some people, but what that tends to do is it increases property values around the areas with the clean, safe, and effective mass transit, so that in a lot of metro areas here in the United States, the relatively low-wage service sector workers can't afford to live in the central business areas where a lot of the work takes place and where the better transit options are, because they get priced out. And so therefore, for these people, commuting 30, 40, 50 miles a day is just something they're going to have to do. and that means they're going to be continuously exposed to motor vehicle traffic hazards for the foreseeable future until some other things occur. So this is why I want you to think about secondary and tertiary strategies in your injury prevention plan and not just think only upstream. Only upstream is not always feasible. It's not always going to be socially acceptable. And there are people, particularly in the lower socioeconomic rungs, who are going to remain vulnerable to the injuries for the foreseeable future, and we have to protect them as well. Another framework in which you can view your injury issue is through the hierarchy of controls. We talked about this back during the occupational injuries lecture, and it is traditionally used for the control of occupational injuries, but it can be used for the control of any types of injuries, not just ones that occur on the job. For the most part, with the hierarchy of controls, we're talking about primary prevention strategies. We stop the injurious event from occurring in the first place. The hierarchy of controls does accommodate some secondary strategies, though, where the injurious event still occurs and we're mitigating the severity of it. That's mostly when we get down to the bottom, the PPE parts, but yeah, for the most part, these are primary prevention strategies. So let's kind of work through this a little bit here. At the top of the hierarchy of controls, the most preferred method would be elimination. You physically remove the hazard from the workplace or from the person's environment, and it doesn't exist. It can't hurt the person anymore. Obviously, if we want to make an analogy to the 4Es, this would be a change to the environment. And where it's feasible, it works really well. Next down on the hierarchy of controls is substitution, where you remove something injurious from a workplace or other environment, but then you replace it with something that can still get the task done, but that is perceived to be less hazardous. A good example of this would be a lot of people who work in the dry cleaning industry were being injured by exposure to trichloroethylene solvents. And so many years back, through actions of the EPA and OSHA and just from and Consumer Product Safety Commission, trichloroethylene was largely replaced by perchloroethylene, which was shown to have, by research, to have a much lower degree of human toxicity. It still doesn't have no human toxicity, but so that's the thing. If you're going to do substitution, yeah, that's a change to an environment, but you also have to do some research to make sure that the new thing you're introducing actually is safer, or that it's not introducing its own unforeseen hazards that you bring in with it. Below that is engineering controls. Again, these isolate people from the hazard. They're really good at that. Chemical fume hoods are an example. Guarding that goes over belts and pulleys on a piece of machinery. Again, the hazard is there, but people are isolated from it. In this, if you want to make an analogy to the 4Es, certainly it's engineering, but also it's enforcement. If you have engineering controls in a workplace, for example, sometimes people find it's quicker and easier to do the job without the engineering controls in place or the guards. So you have to have some degree of enforcement to ensure that people know that, no, if you're going to do this, you have to have the controls in place, even if you perceive it as inconvenient or any other reason. It's there to protect you, to separate you from the hazard. You must use it. Next down on the hierarchy of controls are administrative controls. This is changes that are made to the way people work, or in the case of non-work environments, the way that people interact with a particular hazard. And for when we get to administrative controls, we're dealing with engineering, enforcement, and education, potentially. And at the very bottom of the hierarchy of controls is personal protective equipment, or PPE. And really, in both the occupational and non-occupational realms, when you're putting on PPE, there's kind of a tacit acknowledgement that what's happening is that the hazard exists. It's in immediate proximity to you. Nothing upstream was applied or could be applied, or upstream solutions did not completely eliminate the hazard. So therefore, you have to basically armor yourself with this personal protective equipment in order to be effectively protected. This is why it's often considered the last line of defense, and it's at the bottom of the hierarchy of controls. But it's still very critically important to use PPE. And if you want to have an analogy to the 4 E's, it's probably education and enforcement, because PPE doesn't automatically put itself on. People have to choose to put it on. They have to be educated on why it's important. And sometimes in a work setting, for example, you have to actually enforce rules about it, that you will put on gloves every time you're in the lab, or you'll put on the face shield every time you use a grinder. So yeah, that's the other limitation of PPE. It doesn't automatically put itself on, so you sometimes have to involve enforcement and education with it. So now we come to the Haddon matrix. This is a visualization tool that you're going to use in assignment number 2 with your selected injury topic. This is an example of what an empty Haddon matrix looks like. On the left side, you will have the 3 temporal phases: pre-event, event, and post-event. On the top row, you'll have 4 categories of contributing factors: human factors, agent or vehicle factors, physical and sociocultural environmental factors. We'll go over some examples of this, but first I want to explain a little bit of the history of the Haddon matrix. The Haddon matrix was developed by and named after Dr. William Haddon, who also happened to be the first chairman of the National Highway Traffic Safety Administration, that agency I talked about when we were talking about Ralph Nader and unsafe at any speed several lectures ago. But anyways, back in 1970, Dr. William Haddon developed the Haddon matrix as an extension of the public health model of injury control. And it really is quite handy as a tool for planning countermeasures against injury and for developing prevention strategies at different points in time. So a Haddon matrix you'll have to do temporal analysis, a time analysis of 3 different time phases of the injury event. These will include you'll not just look at the injury event, but also the potential solutions to the injury event can occur in all 3 phases. The pre-injury phase, where, again, the injury has not occurred yet, so this is where primary prevention measures would come in handy to stop the injurious transfer of energy from occurring. The injury phase, this is where secondary prevention measures are utilized. This would be an example of like personal protective equipment. If you're wearing a hard hat on a construction site, it doesn't stop things from falling on you and hitting and bouncing against your head, but you're going to be a lot more protected, and the injury is going to be a lot more mitigated if a bolt falls on your head while you're wearing a hard hat versus not wearing a hard hat. So again, that's the injury phase. The injurious transfer of energy is still happening, but we're trying to come up with secondary measures to mitigate the severity of the energy transfer. And then at the post-injury phase, at this point, yeah, the bad thing has already happened. A hazardous transfer of energy has occurred and an injury has occurred. In this case, we're thinking about tertiary prevention measures, like how quickly can medical care get to a person? What level of care and rehabilitation is available to them to maybe regain some lost function? When you get to tertiary, it's like either the secondary mitigation strategies were not there, they didn't work, or they didn't absorb enough of the hazardous energy, and the person absorbed a critical amount of hazardous energy, and now they need tertiary care. But those are the 3 temporal phases of the Haddon matrix. The top column of a Haddon matrix will contain the contributing factors. They can be contributing factors to the injury itself or contributing factors to the prevention or mitigation of the injury, depending on if you're doing the injury matrix or the injury prevention matrix. The first category of contributing factors are human factors. If we want to think in terms of the epidemiologic triangle, we could call these host factors. What are the things that humans do which might increase their susceptibility to the injury? Or if we're trying to come up with a preventive matrix, things that humans do which could decrease their susceptibility to injury. The preventive strategies that go into the human factors column, they might focus on education, enforcement, or engineering. These are generally not going to be the focus of upstream or primary prevention interventions, because those are more environmental changes. We're talking about the things that humans do that make them more susceptible, the things we can get humans to do to make them less susceptible. So again, it's not particularly upstream, but it's still an important column of any Haddon matrix. The next column of contributing factors will be the agent or vehicle factors. Again, think in terms of agent if you want to visualize this as an epidemiologic triangle. What is this object or this person or this piece of equipment or this circumstance that's transferring injurious energy to the host? And what are some things we can do about it? Preventive strategies in the agent or vehicle factors category of the Haddon matrix, they might focus on education, engineering, enforcement, or really far upstream to environmental changes. Really, agent or vehicle factors are where we often represent clear opportunities for what I call midstream interventions. Those things where you stop something early before too much injurious energy occurs. Sort of like the hard hat example I used earlier. This is also where a lot of secondary prevention strategies occur, what we might call target hardening, where in the cases of a literal vehicle, we design a vehicle so that much of the crash energy is absorbed by the vehicle or by the safety equipment before it gets into the people inside the car. A Haddon matrix will also have two categories of environmental factors, starting with physical environmental factors. These are the physical conditions that contribute to the occurrence of injury events or possibly to the prevention or mitigation of injury events. Physical environment factors are generally most amenable to engineering solutions. There can, however, be a role for environment, education, and enforcement as well. And physical environment factors will be present in all temporal phases. They will be there before the injury occurs, while the injury is occurring, and after the injury has occurred. Sociocultural environmental factors, that's the political and legal environment and the cultural norms that we all live in, which create the lived experiences that can lead to the occurrence of injury events or the reduction of injury events. Probably the best way to influence sociocultural environmental factors is through education and through direct environmental change. That can probably most improve sociocultural factors to reduce injury risk. There is also a role for enforcement and engineering. Engineering can certainly can make some improvements, and enforcement can shift sociocultural norms. Sociocultural environmental factors are present in all three temporal phases: pre-event, event, and post-event. Within your Haddon matrix major assignment, I've included an example. In this case, the example being trying to prevent falls from scaffolding on construction sites. The way that you need to do it is just like I'm showing you here. You just start with a table that's actually the conditions that can lead to the injury event or increase the severity of the injury event. So in other words, start with a table of the bad things, and you put them in the human factors, agent vehicle factors, physical environment, sociocultural environment at the pre-injury, injury, post-injury phase. And you'll see in this example I've given you here, there's at least a couple where it's not applicable. And it's okay to say that. The intention then is that you use that table of conditions that can lead to an injury event or increase its severity, and then on the next table, for countermeasures and intervention strategies, you basically address those issues head on. Of like, okay, if this is the bad thing, what can we do to stop the bad thing? And then you list it just like you see here. And again, some of them, you won't be able to find something to fill that box, and that's okay. The Runyon article you were assigned in this week's module talked about the Haddon matrix. It also talked about Haddon's countermeasures. These were also developed by William Haddon at roughly the same time that he was coming up with his matrix. These 10 countermeasures are ways to basically prevent a hazard from happening or to prevent people from being injured by a hazard. They're not all inclusive, but they're still a very thorough set of 10 measures that nicely complement the temporal phases and the factor categories of the Haddon matrix. Let's go over an example of how to use this. The example in the Runyon article of using the Haddon countermeasures had to do with something that was not an injury prevention topic, or at least not in a traditional sense, reduction of cigarette smoking. But let's now use it in regards to what clearly is an injury prevention topic, preventing falls in healthcare facilities and patient care facilities. I won't read all of these to you. These all come from Bradley's Using Haddon's Matrix in an Aggregate Review of Falls from the journal Patient Safety and Quality Healthcare. And in this case, we have patients who are vulnerable because some of them have balance and vestibular issues, some of them have other underlying fragilities, and we want to prevent falls in healthcare facilities. And so with every one of these, you see examples, like number one, prevent the creation of fall conditions. You eliminate slip trip hazards. You make sure that patient room lighting is engineered to ANSI standards so no unexpected trip hazard emerges, especially amongst people that might not have the visual acuity of people who are not in a healthcare atmosphere. So again, I won't read all 10 of these to you. These are in the slides. You can pause now and look at them, or you can look at them in the slides, but this is an example of how all 10 of the Haddon countermeasures can be applied to an injury issue. Now let's talk about the 3 upcoming major assignments that have to do with your selected injury topic. I would highly encourage you to use several different frameworks for injury prevention on these next 3 major assignments. Think about your injury topic in terms of a lot of different frameworks. This will help you to dissect your injury topic into component parts and develop some creative prevention strategies, based on things that happened before, things that happened in the cultural environment, things that happened during the injury event where you can mitigate. This will help you a lot if you apply several frameworks for injury prevention to your injury topic. The first of those 3 major assignments, the Haddon matrix assignment, I'm going to ask you to make 2 matrices or tables, very similar to the ones I just showed you, where the first matrix, and you'll list the conditions which lead to the injury, sorted into the appropriate temporal and factor boxes. The second matrix sheet you will complete will contain specific prevention strategies or countermeasures for the injury, sorted into the appropriate temporal or factor boxes. And there's an example that's available in the assignment showing you how to do this for, I believe it's a construction scaffolding falls injuries, and how they occur, how they can be prevented. So feel free to use that as an example. With your boxes and your matrix, just be specific and be creative. Even if you come up with a prevention strategy that's unproven or even theoretical, this is mostly an exercise in creativity. It's going to help you design a multifactorial injury prevention plan for the assignment which comes after it, the injury prevention plan assignment. And also, don't worry if you can't fill out every single temporal and factor box in a Haddon matrix. Sometimes you just can't come up with something, and the example in the assignment shows you what to write if you can't come up with something. The assignment that comes after the Haddon matrix is the Injury Prevention Plan major assignment. And as a reminder of why we're doing injury prevention plans, public health is about more than just recognizing problems. Yes, monitoring the health community is important, documenting rates and disparities and things like that. That's very important. But we have to do more than just recognize problems. We need to propose solutions as well. When you've looked at your injury topic through all the frameworks I've talked about and completed a Haddon matrix, by that point you're going to be well on your way to completing an interesting multifactorial injury prevention plan. Read the assignment number 3 instructions carefully. Include everything that is asked for in the assignment instructions. Don't overlook any of them. And as a reminder, like I talked about before with the river analogy, try not to have all of your strategies focused on primary prevention or elimination or upstream. This is where we tend to focus a lot of our attention in public health, and rightly so. But a good injury prevention plan should also include how are we going to protect people who are going to remain susceptible to the injury for the foreseeable future. Again, the people who can't afford to live near public transit or whose neighborhoods aren't going to be built out for dedicated bicycle lanes anytime soon, or for people who love to swim and are not going to give up swimming just because it puts them at risk of drowning. Like, How are we going to protect people downstream? Don't forget to include some of those elements in your injury prevention plan. The other major assignment having to do with your selected injury topic is assignment number 4, the academic poster. An academic poster, again, is a way to present your injury prevention plan for your selected injury topic in a very sleek, visually interesting format. Your academic poster will contain key selected information from your injury prevention plan. It shouldn't be your whole entire injury prevention plan. A big, tiny font wall of text on a slide would not look very good, would not make for a good poster. So just kind of have key summarized selected information from your injury prevention plan on it. You will create the poster in PowerPoint and present it as a YouTube upload. Further instructions for how to do this are in the assignment. And keep in mind, an academic poster is not a traditional PowerPoint presentation. It's just one slide. You have to fit everything you want to talk about onto that one slide. Again, not a traditional PowerPoint presentation. It does mean you might have to get kind of small with some of the fonts and creative with your placement, but that's what it is. It's a poster. Visualize it being printed out. It's just one slide. The poster should not just contain words and information. It should have some visual interest elements to it as well. It should contain graphics, tables, maybe some contrasting colors, and again, just to make it more visually interesting. Here's an example of what an academic poster should look like. Yeah, this is not from an injury prevention topic, but still it kind of conveys, I think, how an academic poster should look. It'll have a big header on the top with the name, in this case, the name of your injury prevention plan, and then the name of the author below it. Make sure to put your own name on your injury prevention plan academic poster. And there will be a couple columns of information sorted into categories. In this case, we have an introduction, we have methods, results, and a discussion. And as I'll talk about in the next slide, your academic poster probably won't have those exact same 4 types of information, but still it'll have information divided into categories. And it's good to have like a visual interest element in it. In this case, you have the house and the fruit, and a few of the key points of the poster are in the middle in bigger font, so that if somebody can't stop to read the entire poster, if they read the 3 important points that are in contrasting color in the middle in bigger font, they'll kind of understand what it is that you, what kind of work you put into this and what the results are. So the poster example I just showed you is a more traditional academic poster, and it had an introduction, methodology, results, discussion, and references. Your poster for your injury prevention plan will probably not have those types of traditional sections. Instead, it's probably going to be divided into the following types of categories. It'll have a background on it. This is where you provide important information on your injury topic. Provide some data on morbidity and mortality rates, if it's a subject for which that data is available. Maybe some socio-demographic data on who is most affected. What's the estimated annual cost of injury for this particular injury topic? Just things like that. That's what's going to go into your background section on the academic poster for your injury prevention plan. Then will come a literature review. It doesn't have to be the full literature review, but just summarize a few key interventions that have maybe already been tried for your injury topic. Then will be the proposed intervention. This is where you summarize the injury prevention plan that you are proposing. This will probably be the largest section of your academic poster. It might take up most of the right side of your poster. This is the place where you would see results and discussion on a traditional academic poster. And again, you can use graphs and tables as needed to sort of neatly summarize your results. Bullet points are probably better than whole paragraphs, but just whatever way you think adequately conveys the important bits from your injury prevention plan onto the poster, use that. And then the very last section will be references. And those can be very tiny font, as you saw in the example. So that's it for this week. Good luck on the remaining injury topic assignments and with everything else the rest of the semester. Please reach out if you have any questions, comments, or concerns. Thank you.